Go ahead. Yes.
Panelists and also attendees, we are privileged to have back the second week of webinar in gastroenterology, and we are privileged to have you, Dato, again to chair this session. So please welcome, and without further ado, we'll proceed with this second week of webinar.
Yeah, thank you very much, Dr. Jiwan, and good afternoon to everybody. Those of you who are online to join the second week of the weekly webinar started by the College of Physicians focus on gastroenterology and hepatology in the month of December. I have the pleasure to introduce to you our speaker for this afternoon is Dr. Kuang Keat. He is based in Hospital Sultanah Bahia in Alostar. He has been there for quite a long time, 2006 till now. He got his MBBS from Master in Internal Medicine from USM. And soon after that, he enrolled in the gastroenterology subspecialty training. And he spent some time in Kota Baru and in Hospital KL. And in his final year, he spent a year in Royal Melbourne Hospital, Australia. And at the moment, he is actively involved in training the gastroenterology fellowship program in the country. And he just told me that at the moment, there are about 44 trainees, which is a very good number. Now, besides being a clinician, he has been quite active in research as well. And he's involved in research in treatment of Hep B, Hep C, liver cirrhosis, diabetic gastroparesis, and in ulcerative colitis. And he has published 18 papers in peer-reviewed journals. His topic for this afternoon will be on hepatitis B in pregnancy. And the floor is yours, Dr. Kiew. Please go ahead.
Thank you, Dr. Kiew, for your kind introduction. First of all, I would like to thank the College of Physicians as you organize this platform for us to share our knowledge and experience in the management of the gastroenterology and hepatology problem. Okay, the topic that I chose today will be the hepatitis B in pregnancy. Because I think hepatitis B has been, not to say neglected, but usually it's not a stress problem. We will assume that hepatitis B is just a infection. And if you ask our patient, most of them will say, I'm chronic carrier. But in our gastroenterology clinic, we see a lot of patients come with a complication of the hepatitis B. So we see quite a number of hepatoma, liver cirrhosis, and some of them have a flare of hepatitis B during their follow-up with us. Okay. So in Malaysia, mother-to-child transmission is the major route of transmission of hepatitis B. So without immunoprophylaxis, risk of infection in infant born to mother with hepatitis B is estimated to be 70 to 90% in the E antigen positive patient and 10 to 14% in the E antigen negative mothers. So vaccination program in Malaysia was started in the early 90s. So that is about 30 years ago. We have to ask ourselves, does it work or not? Yes, we do see there is reducing number of patients with hepatitis B, but sadly, there are still patients that come to our clinic who are either a teenager or young adult. Some of them even come with a liver cirrhosis. And most of this group of patients, they are for vertical transmission. So in this today's topic, I would like to discuss what further thing that we can do to reduce the prevalence of hepatitis B in Malaysia.
Sorry, Dr. Kiew, you have not changed the slides.
Sorry. Can you see? Let me just share again. Can you see the slide, Dato?
You can, but it's still the first page.
Why is not sharing? Sorry about that. Let me just check why it's not sharing. What about now?
It's still page 1.
Can you see, Dato?
No.
No.
Okay. Now the slide is here.
Okay.
That's
Sorry
good.
about that. It's
Yeah,
not moving.
okay.
Okay. So what can we do to further reduce the incidence on the prevalence of hepatitis B in Malaysia? Okay. When we talk about maternal to fetal transmission, it can occur in 3 ways. One is intrapartum, peripartum, or postpartum. Most of the transmission actually occur at the peripartum time, where there is there's contact of the maternal blood and fluid with the fetus blood. So there is a transfusion of maternal blood to the fetus during the contraction, and sometimes there is infection during the rupture of a membrane. And when the some of them actually occur when there is a contact with the infant mucosa membranes with the infected secretion of blood in the maternal genital tract. But some of the infection actually occur earlier on. That's the intrapartum transmission. That's why in the patient that whose mother have a very high viral count, we advise not to have instrumentation during the earlier in the pregnancy to avoid the transmission to the baby. Postpartum infection is not common now because of the we are doing the universal vaccination for the baby. So before we go further on the maternal to child transmission, we have to have a look at what is hepatitis B and how it affects us. If we acquire the infection earlier on, you will have acute hepatitis B. In the maternal to child transmission, there is significant number of them will progress to chronic. But whereas if you acquire the infection in the adulthood, most of you will have a resolved hepatitis B. And so now the problem is there is no cure in hepatitis B. What we can achieve actually is a functional cure. What is the meaning of functional cure? Functional cure, it just means that you have sustained clinical resolution of the hepatitis B without the drugs. And if you do a liver biopsy, they have no inflammation. And the patient serology will be HBs antigen negative and anti-HBs positive. Complete cure, which we can't achieve by the current treatment. Also, the patient have a functional cure plus the loss of cccDNA in the hepatocyte. What we are facing now actually is a group of patients with chronic hepatitis B. Chronic hepatitis B, even though now we have the patient have the habit of saying that I'm just a carrier, but we have to understand that hepatitis B is a dynamic disease. You will not remain in carrier state for the rest of your life. So they have 4 phases of chronic hepatitis, which we'll talk about it later. And if the patient have active hepatitis B, because of the inflammation and the scarring in the liver, they will come with us with the complications. Complications usually occur at the 3rd or 4th decades of life. This include liver cirrhosis, which the patient might present with portal hypertension, like they present with variceal bleed, ascites, or hepatorenal syndrome. Some of them will present with liver failure. And we also notice that the patient with hepatitis B, especially the patient with a lot of scarring in the liver, they are at higher risk of hepatoma. In my clinic now, we are seeing a lot of hepatoma that is due to the chronic hepatitis B. So as I said before, if you acquire the infection earlier on, newborns have a 90 to 95% of risk to progress to chronic hepatitis. If they acquire the infection at the infant or children stage, so they have about 20 to 40%. Adult usually will have about 5% of progress to chronic hepatitis. Most of them will resolve after the acute infection. So our encounter with hepatitis B patient in pregnancy, which group of patients we usually will see? One of them will be those patients under our follow-up who were on antiviral therapy. The other group will be the mother that have been detected to have a positive HBs antigen during their antenatal screening or routine screening. So what should we do for those mothers that are on antiviral therapy and they get pregnant? So there are 3 guidelines that usually we refer to. There's AASLD, there's a US guideline. ESA, European guideline, and PASA is the Asia Pacific guideline. All these guidelines will say that if a pregnant mother, if a woman who was on antiviral get pregnant, if they are on tenofovir, we should continue with the tenofovir. If they are on anticaviar, we should switch to tenofovir. And the other antiviral are not commonly used now, such as dalbavancin, lamivudine is not a common antiviral that we're using now. So for those patients that are on treatment, for those on tenofovir, we continue. For those on anticaviar, we switch to tenofovir. Okay. What about the group of patients that are not on treatment? At booking, what should you do? It's fortunate for us in Kedah, most of our family medicine specialists will refer to us, the patient with hepatitis B who are pregnant. So most of the basic investigation will be done by them. So at booking, usually at a 1st or 2nd trimester of pregnancy, we should have a liver function of the patient to look at whether there is inflammation. We need to know the E antigen and anti-HBe status of the patient. We need to know the HBV DNA, that's viral load of the patient. And we need to assess the patient for evidence of cirrhosis, either clinically or biochemically, or sometimes we do radiological imaging. So these are the phases of chronic hepatitis B that I'm talking about. E antigen positive chronic infection means the patient will have very high viral load, but there is very minimal liver inflammation. For those that the body try to clear the virus, which last time we call it immune clearance state. The patient, usually the viral load will drop a bit and the ALT will go up. That means there is inflammation, there's active the body is trying to clear the virus actively. If the patient is successful in clearing the virus, they will go to E antigen negative chronic infection. But for those patients that fail to clear the virus, there will be a persistent liver fibrosis because of the damage to the liver during the interaction between our body immune system with the virus. Some of the patients that go into E antigen negative chronic infection, there will be a mutation of the virus. And this group of patients, we're calling that as a reactivation of the hepatitis B. They have a lower level of the HBV DNA. So, guidelines, recommendation when to start treatment for non-cirrhotic. These are the guidelines for the, if you look at it, AASLD, APASA, they recommend that for those patients that E antigen positive patient, if their viral load is more than 20,000 IU per ml, and the ALT is more than 2 times upper normal limit, they should be started on treatment. ESA have a lower threshold to start treatment. Any patient who has a viral load of 2,000, they should be started on treatment. For E antigen negative patient across the board of the guideline, they recommend that HBV DNA more than 2,000 IU per minute with the ALT more than 2 times upper normal limit, we should start on treatment. If we are in doubt, actually we can assess for liver fibrosis by doing an imaging, which is called the liver stiffness test. You can have fibroscan or liver shear wave to assess for that. In the pregnant lady, if possible, we try to defer treatment if there is no significant fibrosis or cirrhosis. And all the baby that born to the mother with chronic hepatitis B should have vaccination at birth, at 1 month and at 6 months. And hepatitis B immunoglobulin should be given within 12 hours of birth over the other leg. So we should not administer the vaccine and immunoglobulin at the same site. It should be at the different site. So even though we practice universal vaccination and we give HBIG for most of our baby that born to the hepatitis B mother, do we have evidence to suggest that it reduces the risk infection? Actually, we have. In this meta-analysis, you can see that the patient that was given vaccine fare better. So there are less baby that get the hepatitis B. Whereas in this paper, on the Hep B immunoglobulin in the baby, it also showed that the human hepatitis B immunoglobulin actually, if given to the baby, they fare better. There are reduced incidence of hepatitis B in them. And this paper actually is a combination of HBIG and hepatitis B vaccine. If you look at it, the patient that the baby that was not given immunoprophylaxis, more than 90% of them will acquire the infection if their mother is E antigen positive. For those that are given immunoglobulin alone, they are 26%. But if you give combination, the infection rate in the baby will drop to 3 to 7%. most of the study on vaccine and immunoglobulin was done in the 1990s. This is because after that, most of the country practice universal vaccination. So it's not ethical to do a study on that after that. So we have to ask ourselves why the patient given vaccine and immunoglobulin will still acquire the infection. Of course, we will blame on the delay in the administration of HBIG, which is still a real issue at the current time, and failure to complete the vaccine series. But if you look at the previous study that are in the study, all the patients are given immunoglobulin as well as the vaccine. So we will assume that our failure rate will be higher than 3 to 7%. So most of those fail, actually the mother have E antigen positive and very high HBV DNA. If you look at this study from Weizmann, all this group of patients were, the infants were given immunoglobulin and vaccine within 12 hours of birth. So if you look at the infection rate in the baby, most of the all the infection actually occur in the patient who are the mother who are E antigen positive. And then if you look at this graph, you will see that the higher the viral load, the higher the risk of acquired infection. So this graph will show better on the higher the relationship between the maternal DNA, the viral load, compare with the risk of infection. If you look at it, the higher the viral load, the higher the risk of infection in the children. So what can we do to further reduce the risk of hepatitis B in the newborn? If we look at the ESA, AASLD, and APASA guideline, they do suggest we start prophylaxis. That means we initiate antiviral treatment in the pregnant mother at the 3rd trimester. Most of the guideline will say we start around 28 weeks. ESA say initiate treatment within between 24 to 28 weeks of gestation. For those mother that the HBV DNA is more than 200,000 IU per mil. If you convert it to copies, it will be 6 log 10 copies per mil. It's the same for those in the AASLD guideline, and in our Asia-Pacific guideline, it's stated that we should initiate the antiviral therapy at between 28 to 32 weeks of gestation. We can either use tenofovir or tabivudine because these are the drugs that is in the class B, which is safe in the pregnancy. So if you look at another chart, this is the recent guideline from WHO. If you look at it, our guideline will say that tenofovir is the drug of choice to be given as an antiviral treatment to prevent maternal to child transmission of hepatitis B. So since all the guidelines say we should start tenofovir, do we have evidence that tenofovir reduce the risk of maternal to child transmission of hepatitis B? If you look at this study, those patients that were given tenofovir have a lower, the baby have a lower incidence of hepatitis B compared to those that are in the control group. It's the same as in this trial. So most of them will say that if we initiate antiviral therapy at the 3rd trimester of life, will further reduce the risk of transmission of hepatitis B to the newborn. Okay, these are the guidelines. This algorithm that I made after I get all the information. So what we should do is actually, for those patients that is E antigen positive, that does not require treatment. Those who are more HBV DNA more than 6 logs, 10 copies per ml, we should start maternal antiviral prophylaxis at week 28 to 32 after discussion with the mother. Because it is important for us to discuss with the mother why do we start antiviral therapy, which is short-term rather than long-term. Even though we start antiviral for the antiviral prophylaxis, we must stress to the mother that the baby should get vaccinated at birth. The immunoglobulin should be given within 12 hours of birth. And the other issue that we need to monitor, actually, we know that those mothers with hepatitis B have a risk of hepatitis flare after the delivery. So we should monitor for evidence of flare of hepatitis B during that period. Some of you might ask, when do we stop the antiviral? Actually, there are few guidelines about when to stop. Because if you stop the antiviral too early, you are worried that the patient will have a flare of hepatitis B. And they are worried that the tenofovir which are secreted in the breast milk will affect the baby. We'll further discuss about that later, okay? So, is it safe to practice breastfeeding in hepatitis B mother? If you look at it, most of the guidelines will say it's not contraindicated, except for EPASA, which say breastfeeding is discouraged during the maternal antiviral treatment. But this issue is still, we have to discuss with the patient because of the risk of deformity due to the antiviral is not that high. So if you look at this study, actually the risk of transmission of hepatitis B to the newborn actually is none compared to the formula fed. So breastfeeding is not a contraindication for those mothers with hepatitis B. So the other thing that we need to discuss actually postpartum hepatitis flare, because of the changes in the immune system in the mother that delivered. So there is a risk that because of the immune system is become active, there is a risk that the patient will flare after they give birth. So we should monitor the patient and then for the flare, because even though there is a small risk that they progress into acute liver failure, but we do see pregnant mother with hepatitis B, they have acute liver failure after they deliver the baby. So when to stop the treatment? ESA will say you stop up to 12 weeks after delivery. AASLD mentioned that we should discontinue the antiviral at birth to 3 months postpartum. That is another remark here that mentioned that if we discontinue the treatment, the woman should be monitored for hepatitis flare. HBsAg guideline mentioned that it should stop at birth and when the breastfeeding start, because in the HBsAg guideline, the panels were worried about the effect of the antiviral on the newborn. Okay, these are the algorithm that we should do. Okay. I will share a case that we see. Actually, this case was seen 5 years ago in Kedah. 35 years old, G3P2 at 16 weeks of gestation. She was referred to us as her HBs antigen was positive during their routine screening in clinic kesihatan. When we see her in the clinic, on further questioning, her elder son was also followed up in the pediatric clinic for chronic hepatitis B. So what should we do next? Because this patient is not, was not on treatment at that time. So it should be, we should monitor the liver function. We should do a liver function test, the E antigen status and the anti-HBe and the HBV DNA viral load. And we have assessed her for evidence of cirrhosis. So this was the result. Actually, this was done in KK. The ALT of 18, E antigen positive and E antibody negative. Her HBV DNA actually is 8 log 10s. So if you look at the phases of hepatitis B, this patient have E antigen positive chronic infection, which is the phase 1 on our chart. She have no evidence of liver cirrhosis. What should we do next? So if we follow this algorithm, the patient will be in this group. So after we discuss with her about the antiviral prophylaxis, she agreed to start on antiviral prophylaxis. So the tenofovir will start at the week 28 of gestation. And she was given a letter to our ONG colleague about the need to give vaccine and immunoglobulin for the newborn at birth. So she came for follow-up after her delivery, okay? She delivered a healthy baby girl. The thing is, even though we write a letter, because of I think there will be some miscommunication, the immunoglobulin was not given at birth. But fortunately, the baby girl, at the age of 9 months old, the HBs antigen was negative. If you ask me, I don't know whether our tenofovir play a role here, because there is no study compared to state that if you start on antiviral prophylaxis, there's no need to give immunoglobulin, because I don't think that is an ethical way for us to do, because immunoglobulin has been given universally in Malaysia. With that, I thank you. Any question that we can discuss? I'm happy to do that. Hello, Dato Kiew.
Okay, there are some questions here in the chat space there. The first question, Dr. Kiew, yes, is that where do you inject the vaccine to the baby? Is it the arm, or is it the buttock, or is it the thigh? Where do you inject?
There's been a long time I didn't inject the baby. But usually what we advise is over the thigh. We inject over the both thighs. So immunoglobulin will be on one thigh, the vaccine will be the other side.
Okay. And it has to be given within 12 hours if possible of birth, isn't it? Mm.
After 48 hours, the immunoglobulin have been shown to be ineffective to prevent the maternal to child transmission.
What do you think? How compliant our, clinic kesihatan in implementing this policy?
If you look at my case that I showed just now, the problem
was not given at all.
I did ask our ONG colleague what happened. Because for those mothers that is hepatitis B positive, what they will do is vaccine will be given in the labor room, but immunoglobulin need to be given in the pediatric ward. Because of that, there will be some delay in the administration. I don't know how we are going to be able to overcome this problem.
Yeah, we probably have to sort out between the KK and the ONG people. Huh?
Correct.
There's another question from also related to all this is from Dr. Muhammad Firdaus to say that there's no policy for pregnant mothers for hepatitis B surface antigen screening. I don't think that's true if it has been, pregnant mothers have been screened routinely, isn't it? In all the KKs.
Dato, the screening was only started last year. Before that, it's not a routine to screen for hepatitis B. I did ask about that, that's right. But later the KKM did start the screening of hepatitis B in all the pregnant mothers. I think it started last year.
That one we have to check it up because I thought it has been started for quite a long time. That's how we pick up. So. Yeah. There's another question which is what do you do with pregnant mothers with hepatitis B surface antigen positive? I think you more or less answered it already, isn't it? Yep. Is there anything else you want to add?
The only thing I think they didn't notice that, what do we do for those mothers that are E antigen negative with high viral load? To be frank, actually I can't find any papers on that, because most of the study will say E antigen negative, the risk of transmission is very low. But what happens if the patient have E antigen negative, but their viral load very high, whether there are risks to transmit to the fetus or not? In my own opinion, in my own opinion, if their viral load is as high as more than 6 log 10, we should give prophylaxis for that group of patients, because we only have one time. If the baby acquire the infection, that means they will carry the hepatitis B for the rest of their life.
That's true. But I suppose, E antigen negative pregnancy will be in the older, older women, isn't it? Because it is in the older women that they lose their E antigen and become E antigen negative.
That's one thing. The other thing is most our E antigen negative mother, their viral load is less than 6 log 10.
Okay. Now, I have this question to you. Is that we have started, doing universal vaccination for more than 30 years. We started sometime in the middle of the 80s. You look at Beasley paper is in early 80s. Taiwan started in early 80s, and other country is after that. So in other words, we have been vaccinating, everybody for more than 30 years. The number of people with hepatitis B actually is coming less and less, isn't it?
Correct.
Don't you agree?
I agree with that. And then the number of complications is still less. The best paper, I think, is done in Taiwan, because they start their vaccination, I think, 10 or 20 years earlier than us. So
in early 80s. Early 80s,
because we start in early 90s, so they're 10 years earlier than us.
Yeah.
If we look at their papers, the incidence of hepatoma actually dropped in Taiwan.
Yes. So my question is, do we have any statistics, looking at, pregnancy with hepatitis B those days and what's happening currently? Do we have any statistics on that?
In Malaysia, you mean?
In Malaysia, yes. There may be some studies done which I am not aware of.
Unfortunately, our hepatitis B registry just started recently.
Okay.
So we don't have papers or data on what's the incidence or prevalence of hepatitis B in Malaysia before that.
Okay.
We are still collecting the
unfortunately,
data.
yeah, it would be good to have a look at the data, but I guess that the number of people pregnant with Hep B will be coming less, isn't it? With the
It's
universal
true. After the
vaccination.
vaccination, actually, what I can say is most of patients with hepatitis B currently is actually at their 40s or 50s. We have less patients in the teenager, and although we do see young adult and teenager with hepatitis B, I think there will be some immunoprophylaxis failure somewhere.
Yes. There are a few more questions. I'm just able to open up the chat box and read the question. This one may not be anything to do with pregnancy. What's the recommendation for e-antigen negative chronic active hepatitis? You didn't mention about whether it's pregnancy or not pregnancy. I think you more or less talked about it earlier.
If they
e-antigen negative chronic active hepatitis, I think you mentioned that we should treat them with the TDF, isn't it?
No, if I get it correctly, what they ask, if this is not related to pregnancy, it will be e-antigen negative chronic hepatitis. That is a reactivation phase. They are phase 4.
Yes.
For those,
yeah, carry on.
Okay. For those patients, e-antigen negative chronic hepatitis B, what we will do if their ALT is raised or their HBV DNA is more than 4 log 10, what we'll do, we will initiate therapy.
Yes.
And
the only thing is you don't know for how long, probably for long term, the therapy.
The therapy will most likely be lifelong, or if we can do the quantitative HBs and antigen, if their antigen, the quantitative HBs antigen less than 10 IU, we will maintain the therapy for another year, then we can stop. Most of these patients will remain inactive after stopping treatment. But unfortunately, quantitative HBs antigen is not done routinely.
That's right. Yeah. So we have some limitation there.
Yeah, correct.
There's another question who says that what would be your advice for serodiscordant couple, whereby husband was seronegative? Is vaccination alone good enough for the husband? In other words, the wife is positive.
Yes, in this group of patients, okay, if one of the spouse is positive, the other negative, vaccination is still the mainstay to prevent transmission of the virus to the spouse. But in this group, we'll say it's a high-risk group. We aim for the anti-HBs of more than 100 rather than 10.
Yes.
So it's just like those patients that are on hemodialysis, we aim for the higher level of anti-HBs. Most of the couple actually will not get the infection.
Yes. Okay. How about down the dose of HBeAg, hepatitis B immunoglobulin for the baby, to reduce the risk of the infected HBV infection in baby with mother who has got high viral load. Mother high viral load, so you give double the dose of HBIG for the baby. How about that?
We do not practice that. Usually the trial will mention about 100 microgram. I can't recall any paper to say that you give higher dose of HBIG will reduce the risk further.
Yeah, there's no recommendation.
Yeah.
But I just want to check back again, because one of your slides shows that the primary vaccination is usually 3 doses, isn't it? 0, 1, 6, not,
Yes,
not 4 doses. Huh?
Malaysian practice 3 doses, but overseas some of the country do practice 4 doses. They call it is I think it's called something like rapid. They want the immunity to develop earlier, so they practice earlier. They give at a shorter interval.
Okay, at 2 months, 2 months, isn't it?
Yeah,
Huh? 0,
that
2,
one is
4, 6.
overseas practice, not Malaysia practice.
Yeah, we still give 3 doses. Huh?
Yes, correct.
Yeah, and actually, if I remember correctly, the uptake by the general population is quite high, you know, something like more than 90%.
Sorry, Dato, it's about vaccination?
Vaccination, yes.
Yes, it's quite high.
Yeah, which is thanks to the people working in KK, in the public health people.
Yeah, correct.
There's another question here. If there is a flare of hepatitis B in early pregnancy, that is in the first trimester, and viral load is more than 6 log, ALT is more than twice upper normal limit, no evidence of fibrosis, do we initiate antiviral? I think the question is whether you initiate antiviral in the first trimester.
Actually, this one is a bit difficult to answer. In my opinion, if the patient does not decompensate, first of all, flare of hepatitis B in pregnancy is not that common, because we know that the maternal immunity will drop during pregnancy. So if it happens, if there is no fibrosis, I think we should treat it as the normal individual. That means if there is no risk of decompensation, we should delay the initiating the antiviral.
So, okay, there's one more question here, which says that since the treatment is initiated in e-antigen positive patient with a viral load of more than 20,000, that's been showing in the slides,
Okay.
and ALT increase. So this person want to clarify, why is prophylaxis only indicated for viral load more than 200,000? Prophylaxis means antiviral treatment, isn't it?
Because the antiviral prophylaxis, actually we get it from all the evidence from the previous trial. So you have to, I think we have to weigh the risk and the benefit of antiviral for the mother, for the baby. Actually, it's not for the mother, because there is a risk that previously there is a worry that if you give antiviral to the mother, there is the increase in the congenital abnormality. But the latest paper have shown that there is no increase in congenital abnormality for those patients that was given dalbubudin or tenofovir.
So they're quite safe, even given earlier part of pregnancy. Yeah. Okay. One more question. What blood test to take at the age of 9 months old for 9 months old baby? Is it surface antigen or is it anti-HBs?
If you want to, surface antigen is a must for you to say that the patient is not hepatitis B. If you want to assess for the immunity of the baby, you do check for anti-HBs.
Okay, so it depends on what you want to check, right?
Correct.
There's one question here to say is that, you know, when we are talking about carrier,
okay,
whether it is the right word to use, carrier.
Now we are...
Carrier become infective.
Okay.
Carrier can become infective, of course, isn't it?
That means the inactive carrier state, correct? If I'm not mistaken, it should be that inactive carrier state. That means a stage 3. that the patient, if their mutation of the virus, they can become a reactivation of hepatitis B. So they will become E antigen negative chronic hepatitis B.
But the question is, are they infective or not? Are these people infective to others or not?
Even the carrier state also, they are infective.
Yes.
As long as you carry the hepatitis B virus, you are infective.
Exactly. I think the word carrier state is not.
That's why
it's
I don't
a bit
like
misleading, isn't it? Huh? It should be.
That's why I don't like to use the carrier actually.
Yeah, and patient, quite carried away with the fact that they are only carrier. Huh? They don't have to do anything.
They assume that they will remain carrier for the rest of their life.
There's one question on the spouse. Huh?
Okay.
How frequently do you monitor the anti-HBs, the anti-HB surface antigen of the spouse that is Hep B negative? That means one spouse is positive, the other spouse is negative. Do you regularly monitor the anti-Hep B antibody? I think you mentioned about the titer, it has to be more than 100, isn't it?
Yeah, but this high-risk group, if we look at, I don't have data on this spouse with Hep B. What we have actually is for the dialysis patient. You label the patient have a high-risk group. They suggest that you repeat the anti-HBs every 5 years to check the level. If they drop below the level that you want, you give a booster.
Okay. Yeah, that seems to be reasonable, isn't it? Huh?
Yep.
One more question. How early can we check the baby Hep B status after delivery? How soon you want to check the Hep B status for the baby?
If you look at the study, most of them will check the status between 7 to 9 months. I assume it's because of the vaccination, because we vaccinate the patient complete at month 6. So at month 7 to 9, they will check the HBs antigen as well as the anti-HBs.
Okay, yes. I think that's about all. We still have 5 minutes, but I don't see any more questions. Anything you want to add, or you want to have some learning points or anything that you want to tell the audience?
Actually, one thing that I'm a bit worried about is our healthcare worker. If you ask, in my experience, in the hospital, if you ask the junior doctor, have you been vaccinated? They will say yes. But if you ask them what is your anti-HBs after your vaccination, most of them can't give you the answer, what is their level. Whether, because we know that vaccination have 10% of vaccine failure. So if this group of high-risk population, we label our doctor as or the nurse as a high-risk population, they don't even know their level, whether they are successful to develop the anti-HBs or not. If they have a needle stick injury or they exposed to the body fluid of hepatitis B patient, you don't know what to do. So my advice will be, after your vaccination, please check your response to the vaccine.
We do that in a medical school. For example, where I come from, the student on entrance to do medicine, they will have their surface antigen and surface antibody done, and they usually will know the titer. My question is, what is the titer that you think is suitable for healthcare workers, for medical students and for doctors?
We don't have evidence on that, you know.
Yeah.
I will assume that if you want to label as a high risk, then you say 100. That would be a safer level. Most of us will develop the antibody very high level usually.
Yes, correct. But there's some in their double digits lah. There are few who are in the double digits. Whether they need to have, I suppose we can call them a high risk group lah, isn't it? Huh?
Yeah,
and
if this is called a low level of immunity. If this group of patients we want to be safe, you can give the second round of vaccine for them.
Yes. Okay. So thank you very much, Dr. Kiew. I think that's all we have time for. Thank you so much to the audience, especially those who come up with a lot of interesting questions. It's a very good time of revision and sharing. And we also want to thank the College of Physicians for organizing this webinar. Just want to remind everybody that this is on a weekly basis. Next week, we have something on hepatitis C, and you're all welcome to join. So with that, I'd like to once again thank the speaker, Dr. Kuang Keat, and all the audience, as well as the College of Physicians. Thank you so much.
Thank you, Dato.
Yeah, thank you. Can we close the session?
Yeah, thank you, Dato, for sharing.
Okay. Yes, thank you. So,
okay.
Shall we close the session?
Yes, Dato.
Okay, thank you.